Bismillah ar-Rahman ar-Rahim. Today is a very special day. We have a magnificent professor, Professor Dr. Yasser Abdelhamid, and another magnificent Professor Dr. Faisal Shaheen. Both are expert and with excellency in the hemodialysis, and today we will touch a very important topic and a difficult one as well. It is a continuous renal replacement therapy. Professor Dr. Yasser Abdelhamid is professor of nephrology, Cairo University, coming from the magnificent tree of Cairo University School. He is an expert one in the slow continuous dialysis, including CRRT and SLED, and he is the editor of the hemodialysis with acute kidney injury in the hemodialysis Egyptian guidelines. Today we will understand the topic of and technique, the doses, and when to start and when to end. What is the best anticoagulation? What is the best indication? And what is the difference between CRRT and other slow technique like prolonged intermittent renal replacement therapy? I think we are all anxious to hear Professor Dr. Yasser, and will be focused on that issue, followed by the discussion. And Professor Dr. Yasser, I would be happy to continuously monitor your slides, and let us go. Thank you very much for your time, and I believe that all will be an illuminating and understanding this technique very carefully. Thank you very much, and please start.
Thank you. Bismillah ar-Rahman ar-Rahim. Thank you, Professor Hisham, for your very kind and nice introduction. It's my honor to be with you today as a speaker, having you as a moderator together with Professor Faisal Shaheen. You are the hemodialysis man of Egypt, and
thank you very much.
Thank you. And Professor Faisal Shaheen is with us, and even he will join us in a few minutes. I would like to welcome all our attending physicians and our attending colleagues, our attending professors in this meeting. And I hope this meeting to be upon to your expectations. And excuse me to start. I will start CRRT user guide trying to illustrate how to use this modality of renal replacement therapy in intensive care unit and in acute kidney injury as much as I can from the clinical point of view. Let me start by this small statistics. In 2007, 80% of patients with AKI in ICU are currently treated with continuous therapies, and 17% with intermittent therapies, while 30% only with peritoneal dialysis or slow ultrafiltration. And I think this was in 2007, and we are to expect this number to increase by this time by the availability and better understanding of the modalities. I am to stress on this point on the start of my talk that the hemodynamic stability of the critically ill patient is the main determinant of the choice of dialysis modality. To choose one of dialysis modality and to prefer it over the other, we are to look for the patient from the hemodynamic point of view at first. And second, of course, what is the need of this patient regarding the clearance and regarding ultrafiltration, etc. My agenda today will include I will speak about CRRT principles, indications, descriptions, including modality, membrane, choice, replacement fluid, anticoagulation use, and finally I will finish by dosing. Starting by principle, CRRT principle. Available, as you all know, excuse me to revise this rapidly, or available renal replacement therapy rely on two basic principles, including diffusion and convection. And of course, dialysis depends mainly on diffusion, while hemofiltration mainly uses convection. Diffusion, as we all know and all audiences know, depends mainly on the exchange of solutes by osmotic gradients from higher concentration to lower concentration, while convection uses pressure as a forcible method to push solutes in the other side of the membrane. Regarding CRRT, the two modalities can be combined using continuous veno-venous hemodiafiltration. And the name veno-venous came from the access. As in the start of the use of this modality, the forced power of pumping of blood was coming from the arteries. They used the arteries, so they used CAVHDF, continuous arteriovenous hemodiafiltration, which is no more used now, and all is used as continuous veno-venous hemodiafiltration. This means when we use this modality that we combine post-diffusion and ultrafiltration as in use of hemodiafiltration. This is a famous diagram showing the molecules that are removed by using hemodialysis. Diffusion includes small molecules, including PO and creatinine, and larger molecules, including middle molecules starting from vitamin B12 up to light chain A, are considered in the range of middle molecules, are removed by mainly hemofiltration. So when combine the diffusion and convection together, we can remove all small and middle molecules, while very large molecules larger than 15,000 Daltons are removed by therapeutic plasma exchange using plasma filters. What about absorption? Absorption uses a specific type of membranes that catches the materials from one side and leaving the other side of the membrane, the filtrate, almost clear of this catched material. As you can see, for example, if we use adsorption, which is used for cytokines, we can see that the blood side is full of this material and the other side nearly contains no concentration of this material. Regarding comparison of CRRT and intermittent hemodialysis, as you know, intermittent hemodialysis depends mainly on its clearance on diffusion, although nowadays hemodiafiltration can be done simply using the hemodialysis machines. High clearance mainly for small molecules by using depending on diffusion. The use of dialysate, which represents a problem in the ICU settings that we need dialysate and the specific management of dialysate with including water management and etc. and water tubes, which are difficult to be used in the ICU. High dialysate flow, which carries hemodynamic instability and carries having the advantage of having no anticoagulation. We can do it heparin-free and avoid the hazards of heparin, especially in critical patients having bleeding. While looking to CRRT, it depends on both convection and diffusion. So as I said, we can clear small and middle molecules. No need for infrastructures in the ICU. We can use simply the CRRT machines that includes all its components with no other need for other infrastructures, but carries the disadvantages of using the substitution fluids, high amount of substitution fluid with its high cost, and the need of continuous anticoagulation. Of course, we cannot imagine that continuing to up to 24 hours extracorporeal treatment without having even anticoagulation. Although heparin-free methods can be done in using CRRT in some techniques, but with difficulties. And usually, from our experiences, it carries the risk of many times changing the set, including the filter and membrane and all of the set due to heparin-free use. So we cannot continue more than even maximally 12 hours by maximum with lower efficiency by using this heparin-free techniques, although it can be done and can be prescribed using heparin-free CRRT. This is simply the circuit. This is the primary circuit of hemodialysis, as you can know, the arterial line and the venous line. And we, upon these two simple sets, we can use, if we use hemodiafiltration, we are to use a substitute fluids on returning in the line or in the venous line, returning to the patient, replacing the amount of fluid forced out of the filter. And in case we are using dialysis, in addition, we are to use a dialysate passing in the other way or in the opposite way as hemodialysis machine to the way of passage of the blood. Here comes the outside filtrate arising from the machine. The filtrate is mainly formed of, in this situation, replacement fluid or the amount of ultrafiltrate that I have set for hemodiafiltration, the amount of dialysate, if I'm using dialysate, I'm using a dialysis mode, and the amount net ultrafiltration I need. For example, if I am setting hemofiltration for 1 liter per hour and using a dialysate solution for 1 liter, another 1 liter in the form of dialysis, and I want to have the patient net 2 liters, for example, 2 liters per 4 hours, we are half liter per hour. So I will have this filtrate of about 2.5 liters, about 2.5 liters. So the filtrate contains the replacement fluid set in diafiltration mode, and the dialysate set in the dialysis mode, and the net ultrafiltration I need, and is represented per hour. This is simply the machine, and we can see that this is the membrane, fixed membrane, and all of these set parameters, including filtration and dialysate, are controlled using specific pumps moving in the specific way or in a specific time. Here we have 4 pumps or 5 pumps really. This is the big pump for blood pump, and the 4 pump, one for the pre-replacement, pre-filter replacement, as we will see. Another is for the effluent, and the other for the dialysis fluid, and the last one is for the effluent rate. The bags used are the bags. This is the effluent bag that contains the amount of fluids I have mentioned, and the other bags are for solutions including the filtrate, the replacement solution, and the dialysate, which are the same bags used and adjusted to be used as a dialysate and as a replacement fluid. Moreover, this is a syringe for heparin, for anticoagulation, as usual in the hemodialysis machine. This is simply the machine set in HDF mode with all fixed bags and blood pumps or pumps operating. And please remember that the scales, these are the scales carrying fluids, which are the very, very important point in this machine. And these scales are very sensitive and are the key element in adjusting the rate of filtration and adjusting the rate of dialysate, adjusting the rate of effluent, adjusting the rate of ultrafiltration. The machine senses the bag as by its scales, and accordingly, this is translated into the amount of filtrate and the amount of dialysate. What are the advantages of CRRT? Include mainly hemodynamic stability. Some reports reported that there is better recovery of renal function with the use of CRRT, better correction of metabolic acidosis, correction of malnutrition. Of course, I can give the patient more and more nutrients and more IV fluids, and for these oliguric patients in view of continuous ultrafiltration. Removal of cytokines, and many reports reported that there is removal of cytokines in sepsis, and the use of CRRT in sepsis is one of the major areas of research in this field. Better solute removal, including better control of sodium, magnesium, and other solids in case of severe or hyponatremia or hypernatremia. Mainly, the main advantage of CRRT are maintaining the hemodynamic stability. It is mainly gradual process. It is mainly gradual process. Gradual removal of solutes and metabolic wastes help to clear inflammatory mediators and ensure adequate nutrition for patients. Please look for these figures comparing CVVH, hemofiltration. CVVH is the same as CVVHF, hemofiltration, with daily hemodialysis using intermittent hemodialysis. This is the control of body weight by intermittent hemodialysis, abrupt drop and then rebound. The same with mean arterial blood pressure, look for these fluctuations. PON, look for the rebound, and bicarbonate. Look, in addition to, in comparison to this, on contrast, the smooth nature of CRRT control of these components. This is the figure as published in 2012 in Journal of Anesthesiology, comparing these two methods. Looking for hemodynamic stabilities, this patients pre-dialysis and intra-dialysis, patients using hemodialysis and the compared method of dialysis CVVH HD, you can see that mean arterial blood pressure drop or difference is much less than with CRRT than hemodialysis. In spite of that, the starting pressure with CVVHD is somewhat lower than the hemodialysis. Why? This is smoothness, maintenance of intravascular compartment volume. If you calculate this simply, 3 liters in 3 hours of intermittent hemodialysis, this means that 1 liter hemofiltration ultrafiltration rate, while 3 liters in 24 hours, 0.125 milliliter per hour. So much difference of ultrafiltration rate that I need, and this gives hemodynamic stability I have mentioned. While urea diffusion, similar, urea clearance nearly 160, while urea clearance is much lower in CRRT, nearly 15 to 30 milliliter per minute, and less risk of disequilibrium syndrome. Sodium removal rates, including hemofiltration and hemodiafiltration, is less than diffusive removal rate, so better control and smooth control of sodium disorders, including hypo and hypernatremia. Better control of core temperature, avoiding the hypothermia that may cause hypotension, and better control of this hypothermia, allowing for better control of blood pressure. Removal of inflammatory mediators and catching the cause and attacking the cause of hypotension, better control of sepsis, and this of course adds to hemodynamic stability. The disadvantages come to the question is that is it really continuous? Which is the answer is really it is no. We need to disconnect the patient sometimes for care, for example, to adjust the position for the patient, for example, to do some investigations. And the circuit is not that continuous in much cases. There is need for interruption, of course, in ICU. In addition to, if we have blood clotting or stoppage of the circuit due to blood clotting, if we are using, for example, heparin-free methods, and this carries the period of change of the circuit, and so the net result, it is usually that continuous process. The need of anticoagulation for 24 hours in a critically ill patient. Patient is attached to his bed. If the patient is moving and is conscious, difficult to move, not tough. Higher cost, of course, and this is the obstacle for our use of CRRT. Lower efficiencies than intermittent hemodialysis if we need to correct rapidly the condition. CRRT is not of a choice, as for example, the hyperkalemia, life-threatening hyperkalemia, and risk of hypothermia, which can be controlled due to long time of extracorporeal circuits. Simply, this is the principle of CRRT, and coming to indications of CRRT. Absolute indications are the absolute indications of dialysis in acute kidney injury, including resistant fluid overload, hyperkalemia, ECG changes, and resistant to treatment, resistant metabolic acidosis, uremic complications, toxins, for example, lactic acidosis due to metformin use can be used continuously in case of metformin, and hypermagnesemia with anuria and absent deep tendon reflexes due to smooth correction of electrolyte disorders. Relative contraindications that are left to the judgment of the physician include fluid overload, diuretic sensitive fluid overload that are moved that can be controlled by diuretics, but oliguria, rifle class, RIF classes of oliguria, higher urea, and serum sodium hypo or hypernatremic side. If we're looking to fluid overload, here comes an important question. We need, in the ICU process, we are to remember that and look for that the patient is in usual need for continuous IV fluid therapy. The patient is in need for, and in this case, we are not to wait for the patient to be overloaded, because of course he will be overloaded. The net result of an oliguric patient, and we need to use nutrition, to use IV fluids, to use drugs, the patient will be overloaded. So to start relatively in CRRT as indication, a fluid overload that is expected in a lower level of fluid overload, not that level, high level of diuretic resistance carries a better prognosis. Is fluid overload per se a hazardous condition? Is oliguria per se a hazardous condition? Here comes this question. And this can be answered through the following slides. Oliguria is associated with worse mortality. This is urine output, and we compare mortality. These are the non-survivors, and these are the survivors, not dialyzed patients and dialyzed patients. You can see that the non-survivors are having a higher urine output, while the non-survivors, lower urine output, while the survivors had a higher urine output, significantly p-less about 0.030. This study in one of the major landmark studies in 2009 by Butchert stated that patients with fluid overload having higher mortality than patients with no fluid overload. The non-dialyzed patient, comparing the non-dialyzed and dialyzed patient regarding weight gain, we can see that weight gain in both dialyzed and non-dialyzed patient carries a higher percent of mortality, both if the patient is undergoing dialysis and the patient is not going dialysis. So why not to do dialysis in this case? Why not to start removing of fluids if we will go to the same outcome in both cases? Percent of mortality comparing percent of dialysis days with fluid overload as the patient is fluid overloaded and increasing dialysis day, you can see that significantly the mortality is increased. And comparing intermittent hemodialysis to CRRT with mean fluid accumulation, we can see that CRRT fluid accumulation is less than intermittent hemodialysis. And this can be expected as we are using ultrafiltration continuously over the 24 hours, while intermittent hemodialysis used only for some hours in addition to fluids used during an intermittent hemodialysis. So the net result of intermittent hemodialysis is having less fluid overload, carrying less hazard of worse outcome regarding fluid overload. So fluid overload, oliguria with the starting fluid overload carries worse prognosis and worse mortality. And we leave this fluid overload, we will go to worse and worse mortality. So early is better. Early is better. Early initiation of CRRT, even as a relative indication, is better. Non-renal indications of cardiac failure with volume overload, which is cardiorenal and may be used even with no renal affection. Large amounts of IV intake, as I said, avoiding volume overload, especially in oliguric patients. Abnormalities of temperature, as in cases of hyper or hypothermia, emergencies due to hyper or hypothermia, overdose with the dialyzable toxin, for example, lithium, or as I have mentioned, metformin. Okay, if you can use, in this case, CRRT would be better. Please remember to use CRRT and put it as one of your first choices in hemodynamic unstable patients. And for me, if you have CRRT in ICU and have a hemodynamic unstable patient, you are to use CRRT and don't go to any other modality. Other modalities, if there is an obstacle or difficulty in using CRRT in hemodynamic stable patients, unstable patients. Acute brain injury, it has a specific indication in lowering cerebral edema, and acute fulminant liver failure with the use of a specific form, and we can use also the specific form of CRRT for fulminant liver failure, which is MARS, liver dialysis. And of course, comes the indication if we have a hepatorenal syndrome for patients with acute renal failure and acute combined acute hepatic failure, we can use both together and just simply using the membrane and attach it to the cell. Cranial hypertension, cerebral edema, autoregulation is lost, and sudden change of systemic or intra-abdominal pressure, change intracranial pressure, and CRRT avoids this sudden change. Abdominal compartmental syndrome, avoiding also the sudden changes of renal perfusion. Correct azotemia slowly, so the avoiding dialysis is disequilibrium, and I have mentioned you that the urea clearance compared to hemodialysis itself. And patients with hyponatremia, correction, slow correction of sodium disorders. What about CRRT and sepsis? Initially, and by the initial studies by Ronco 2000, high volume hemofiltration offered the benefit of conventional hemodialysis in patients with sepsis. Later on, meta-analysis and many studies showed that there is no difference regarding sepsis outcome, although there was high dose resulted in removal of these cytokines, interleukin-1, beta, 6, 10, and with no effect on mortality than a conventional doses of 40 milligram per kg per hour. Generally, in sepsis, CRRT was found to decrease the amount of cytokines, and this is translated into an outcome is questionable. Does this translate to an outcome parameter is questionable. But the decrease of cytokines was proved in studies for use of CRRT than use of usual methods of dialysis, but was not translated into outcome regarding mortality or ICU stay. So this can be translated into the better control of hemodynamics. More and more membranes and use of new membranes of hemoperfusion, for example, polymyxin P membranes, resulting in improvement of hemodynamics and organ dysfunction in sepsis, and use of some of these new membranes, which is as AN69 or Exuris, for example, which was used extensively in the period of COVID, resulted in much improvement in cytokine level and on individual basis, but was not translated into my major till now major results on statistical study. These are the theories how to remove cytokines, and it's not by our scope now. So I have finished my principles and specific indication. Please remember CRRT in hemodynamics patients, unstable patients as your first choice. In sepsis, patient should be considered as a part or adjuvant to specific therapy of antibiotic therapy. When I decided to use CRRT, I will go to prescription, which include which modality to use, what is the type of membrane to use, what's the type of replacement therapy, and how to use replacement, which method, anticoagulation used, and finally the dosing. Let me start by modalities. The modality is the main mechanism by which clearance is achieved, and the ideal treatment modality should preserve homeostasis, does not increase comorbidity, does not worsen the patient's underlying condition, and should be inexpensive, simple to manage, not burdensome to ICU staff. These are the modalities of CRRT. SCUF, slow continuous ultrafiltration, using only ultrafiltration. Hemofiltration, or using only dialysis, or combining both hemodialysis and hemodiafiltration, adding to SLED as a method in addition, or adding plasma filtration, combined plasma filtration and plasma exchange, perfusion, combined perfusion and plasma exchange, coupled filtration and perfusion, We attach a patient into two membranes, one for plasma filter, covering plasma filter, and adsorbent filter, hemabsorption filter. High volume hemofiltration using a specific membrane. So SCUF, we will discuss the main modalities of CRRT machines, including SCUF, CVVH, and HD, HDF, and leaving the other methods containing hemoperfusion, therapeutic plasma exchange, and the coupled plasma filtration absorption into another settings. Many intensivists and nephrologists prefer to use CVVH in the belief that pure convection will remove a greater number of larger molecules than diffusion-based CVVHT. When we use CRRT, please don't waste it in using only hemodialysis. You are to combine the modality of hemofiltration, either alone or combined in hemodialysis and HDF. So CVVHDF is a safe and better combination. Using only in hemodialysis mode, I think for me, this represents waste of the modality and the waste of money using this expensive modality and in this simple procedure. Please combine both modalities together using CVVHD, F, or alone, even in some cases, CVVHF is sufficient. This is a slow continuous ultrafiltration. Simply, and the machine is fixed by its 4 pumps, and we use the blood pump stationary and the effluent pump. These two pumps, the blood pump and the effluent pump are fixed in all modalities. No modalities will go without using a blood pump, and no modalities in pump will go without using out pump, which is the effluent pump. The effluent is usually colored by the yellow line, and the blood is by the red line. You can see that this is a red mark and this is a yellow mark for the effluent pump. We can control simply using ultrafiltration of a slow process at a slow process using this machine. Simply ultrafiltration as we do usually in hemodialysis machine in cases of cardiac failure, for example, in cases of use of cardiac failure, for example. So simply using ultrafiltration using the 2-piece only working 2 pumps. Really, this does not differ much than hemodialysis machine. What this machine can do for ultrafiltration can be done safely by the usual hemodialysis machine. But if we can use and it is present, it will be an good alternative, but does not differs technically much more than hemodialysis machine. Adding into CVVHF, hemofiltration, adding a hemofiltration component using a high volume filtration through the membrane and similar high volume of replacement fluids targeting to remove small and middle molecules. So in this case, the blood pump is working, the effluent pump, and we add another 3rd pump, which is the replacement pump. The replacement pump is working. And in some machines, we can have 2 replacement pumps, one for the pre-filter replacement and the other for the post replacement, as I will mention later on, as in dividing the replacement fluid into pre and post, or using only the pre or only the post method of replacement. So in CVVHF, I am to use the filtration volume in addition to the usual use of blood and effluent volumes. Hemodialysis. Here, I need to pass a dialysate and ultrafiltration only. So the red one is for the blood pump as usual. And the yellow pump is for the effluent. And we can adjust the amount ultrafiltrate. Green is usually for the dialysis pump. Any fluid, any pump that is working as a dialysate will carry the fluid as a dialysate is marked by green. So here another 3, but the red one, the yellow, which are fixed, and the green, which is for the dialysate. The last one, which is the white pump for hemofiltration, is not working here. Here, we are not using a high volume for clearance, just simply using a diffusion. Dialysate passing against the blood, as in hemodialysis. So exchange is only by diffusion, no more filtration and no more clear for large molecule, middle molecules, only for small molecules, and depends only on the membrane, not for the forcing power. Here the clearance depends not osmotic, only by the diffusion by using high volume. So the effluent here contains only the dialysate and the net ultrafiltration, while here contains the replacement fluid and the net ultrafiltration. Combining both together, which is much more logic, includes CVVH-DF. And all 4 pumps are working. Blood, effluent, ultrafiltrate, our replacement, and the dialysate pump. And both solutions, replacement solutions, are put on the scales. And in this way, these replacement solutions are used as replacement both and as dialysate. The same solutions are used in both indications as replacement and as dialysate, the same type of solution. And the machine uses the 2 scales at the same time. These are the main modalities of using CRRT in the ICU, including SCAF, including CVVHF, HD, and HDF. Now, to compare CRRT with other modalities, including SLED, peritoneal dialysis, and intermittent hemodialysis, what about it? SLED advantages include that it is slower, especially in use small QD, dialysate volume about 300 to 500, so much carries more hemodynamic instability. And this is compensated by increasing the period of dialysis more than 5 hours. We can reach up to 8 hours. So this resulted and translated into hemodynamic tolerance. 6 to 12 hours overnight treatment can be up to 12 hours. Patient mobility can be allowed in the free period. And anticoagulation, of course, 6 to 12 hours is better than 24 hours and managing without anticoagulation. Managing lesser hours without anticoagulation is better than 24 hours or less period of anticoagulation. Carries superior clearance than CRRT because the fluid movement, the dialysate movement is much higher. And removal of toxins due to higher flow, we can use, especially with the new types of membrane, as was Professor Hisham usually speaks in all his lectures about the new types of membranes and their advantages in better clearance and their advantages on the outcome. Disadvantages of SLED include the same disadvantages I have mentioned for intermittent hemodialysis, including the need for infrastructure. And not all hemodynamic patients can tolerate SLED. This is from everyone experienced can tell that. Not all hemodynamically unstable patients can tolerate SLED. Some cannot even tolerate SLED. Also, the risk of hypophosphatemia as CRRT, the risk of hypothermia, and lower efficiency than intermittent hemodialysis, although it is higher than CRRT. Regarding outcome, generally reported experiences suggest patient outcomes similar to those reported with other acute therapies. So no outcome translated, and outcome is usually translated into mortality up to 90 days mortalities and ICU stay. But individually, some patients need more in CRRT than SLED patients. This is randomized trials comparing use of extended daily dialysis and CVVH-D, the same method of using dialysis only, not filtration, and they found that viable modality in patients with septic shock as hemodynamic effects are similar to CRRT. Also, mortality and recovery of renal function, acute patients, they studied patients with sepsis specifically to compensate for the specific indication for CRRT, and found that even those patients were on epinephrine, they found no difference in mortality or renal recovery between use of SLED and CRRT. What about the use of PD? Comparing tidal volume PD, high volume PD in CRRT. 62 patients with CVVH-DF compared to tidal volume 63 patients. Found that group A with CRRT and B with peritoneal dialysis found that infectious complications were more in CRRT patients, and recovery of renal function less, and resolution of AKI was more in CRRT patients. Comparing the side effects, you can see that CVVH-DF having a much side effect profile than tidal peritoneal dialysis. And what about mortality? You can see that 33% of patients, 33% of patients mortality in group A compared to group B in peritoneal dialysis, which was significant difference for to the side of peritoneal dialysis, favoring the side of peritoneal dialysis to CRRT. So peritoneal dialysis is nearly a neglected modality in acute cases in ICU. And we are to consider it simply if we do not have the facility for doing SLED. And even if we have the facility, we are to push this modality as one of the acute modalities as well as in the past. What about the indication of this specific therapy? If I have to removal fluids in a stable patient, use intermittent or isolated ultrafiltration post by CRRT or hemodialysis. Unstable patient, cuff or any method of intermittent hemodialysis. If I am targeting urea clearance, stable patient, intermittent hemodialysis, unstable CRRT by all of its means, hemofiltration or hemodiafiltration or hemodialysis. Severe hyperkalemia, stable or unstable, please go to intermittent hemodialysis. Severe metabolic acidosis can be used both with favor of intermittent hemodialysis. Hypophosphatemia, CRRT comes to the first. Brain edema, CRRT comes to the first. And these are the modalities of CRRT, and these are comparing all modalities, including PD, intermittent hemodialysis, intermittent hemofiltration, hybrid methods, CVH, HD, HDF, regarding solute clearance and volume control. You can see that if you are targeting solute clearance and the patient is stable, please go to hemodynamic stability, and not that much in regarding volume control. While CRRT is comparing in all of its modalities regarding solute clearance to hemodialysis, usual hemodialysis, and regarding control of fluid is better, much more better than intermittent hemodialysis regarding fluid control. So it's nearly similar clearance and much more better fluid control. What about the membrane? The usual membrane is used, the high flux membrane, hardly preparated for water. And this, of course, with the use of hemofiltration modes, clearance of low and middle molecules with high biocompatibility. Comparing the new membranes of high flux or high cutoff membranes revealed that reduction high cutoff use in CRRT resulted in reduction of free filter to post-filter plasma cytokine levels was during high cutoff membranes compared with high flux treatment. So if we can use high cutoff membranes in this treatment modality, will be much more better. Comparing HF, HDF with high cutoff in CVVHD mode, use of this type of membrane in CVVHD mode, you can see that CVVHD is better in clearance of a small molecule. But when we come to beta-2 microglobulins, you can find that CVVH-DF with high flux membrane is much higher than high cutoff membrane. Although by 18 hours, nearly two modalities became the same. So if you can combine these two high cutoff membranes together with use of HDF, it will be much more better benefits. The cytokine difference, not that the same. And coming to the replacement fluid. We are to have replacement methods. We have either post-dilution, pre-dilution, or mixed pre and post-dilution. This is pre-dilution. Replacement fluid is inserted into the arterial line before the filter. While post-dilution, it is inserted after the blood passing the filter into the venous line. Next, we are to divide our replacement fluid into simply post and pre-dilution. Post-dilution carries a better clearance, while pre-dilution carries a better hemodilution in case of heparin-free or need for anticoagulation. So hemoconcentration is better with pre-dilution. Post-dilution, more hemoconcentration. With better filter life when we use pre-dilution muscles. No need for anticoagulation when we use better hemodilution muscles. Better convection when we use pre-dilution muscles. But clearance is better with post-dilution muscles. And listen, and arterial filtration control is better with post-dilution muscles. So we are to go to pre-dilution if we are afraid of using of anticoagulation. We are to use heparin-free methods of CRRT or lesser amount of heparin or anticoagulation. We are to put our replacement fluid into the pre-dilution set. Most of some machines can do this, mix dilution pre and post, and this is a better solution for this dilemma. But some machines cannot do post or pre-dilution. You are to choose your way of pre or post dilution. And it is to be mentioned that your program in the start of CRRT circuit will not be changed during the treatment. If you are to change your program, you are to end your treatment and to start a new one again. So please determine your needs at the start of your treatment to determine your program properly. If we need pre-dilution in case of fear of anticoagulation, or in case of need of much high filtration force, and post-dilution if we need more solute clearance in addition to filtration force, and we know no problem of anticoagulation. If we can do this mixed, mainly we use post-dilution in addition to pre-dilution, 70 post to 30 pre-dilution. This is the usual. Replacement solution are either bicarbonate based or lactate based. We started with the use of lactate, but now bicarbonate based, which is ideal based, are present in many concentrations. Of course, you can see that these have more and more lactate, and these have more and more bicarbonate. And regarding potassium solution, bicarbonate solutions can be classified according to their content of potassium. If you're having a hyperkalemic patient, you are to use a lower concentration of potassium, K0, which is called K0. No potassium if my patient is hyperkalemic. And the reverse, we can use a K4 if the patient having a high hypokalemia, for example. And in usual cases of potassium concentration, we can use K2 or K3 having a normal concentration of potassium if there is no problem of change of serum potassium, or I need a specific change of serum potassium. So bicarbonate solution, which is usually used nowadays, can be from K0 to K4 according to their content of potassium, according to the patient needs. This replacement solution is also used as dialysate solution. Anticoagulation methods include no anticoagulation, but clotting carries the risk of clotting. And as I have mentioned, if we are to use anticoagulation in heparin-free, you are to use pre-dilution method. Heparin is the usual risk of heparin, low molecular weight heparin, under trial and not tried, carries more success. Citrate or heparin, which citrate, regional citrate coagulation, carries the risk of hypocalcemia. This is the recommendations for citrate use. Citrate are infused in the arterial line in pre-filter. And in this case, we can use the pre-filter pump to inject the citrate solution in pre-dilution method. Citrate is only injected in a pre-dilution form before the membrane. And citrate dose 3 to 4 millimole per liter, targeting ionized calcium in the filtrate 0.3 to 0.5 millimole. And calcium is infused later on, can be infused separately, calcium gluconate infusion targeting systemic ionized calcium 1.1 to 1.2 millimole per liter. So I am to monitor my target, in addition to monitoring the rate of citrate infusion in the pre-dilution method, serum calcium in the patient while I am infusing calcium on the venous line, as we infuse it usually in the hemodialysis patient. This is the citrate. And the major disadvantages of citrate is two main complications, including citrate accumulation or citrate net overload. Here, incomplete citrate metabolism, and this results in catching of calcium. So the amount of total calcium to ionized calcium is increased. But here, excess citrate administration relative to buffer, simply no abnormal metabolism. The metabolism is normal. The metabolism is normal. So the ratio is normal. This is the main way to diagnose the difference between citrate accumulation and citrate net overload. The amount of total calcium to amount of ionized calcium. The ratio more than 2.5, this is citrate accumulation, and this is citrate overload. This is to differentiate that citrate accumulation is a difficult process, carries the risk of severe hypocalcemia and may be lethal, while citrate net overload is not that dangerous and is usually that benign and can be managed simply by decreased flow or increased dialysate flow rate. Simply decrease the blood flow or increase the dialysate flow rate, decreasing the flow of citrate and decreasing the process of binding calcium. While this needs calcium infusion and may need to stop off citrate and searching for other method for anticoagulation. So please look for the ratio of total calcium to ionized calcium. 2.5 is the cut point. Finally, the dose. And the dose represents more one clinical parameter: adequate toxin removal. This is translated into adequate toxin removal, adequate fluid and electrolyte homeostasis, and adequate acidosis correction. The dose simply is the amount of filtrate. And I have mentioned the amount of filtrate is the amount of substitute added to amount of dialysate in addition to net ultrafiltration. So the amount of filtrate in milliliters per hour is the dose. The amount of filtrate in milliliter per hour is the dose. And this is the representative how adequate my process is. So if I am using CVVHF, the dose represents the amount of substitute in addition to net ultrafiltration, no dialysate. HD, amount of dialysate, net ultrafiltration, no replacement fluid. And if I combine both together, HDF, both substitute, dialysate, and net ultrafiltration. Let me go to this example. The success of CRRT depends on the prescribed and achieved dose of replacement and substitution fluids. Treatment duration, which is usually more than 24 hours. Type of dialyzers I have mentioned, if we can use the new dialyzers, would be magnificent. And the method and dose of anticoagulation to prolong the filter life and ensure adequate filter life. Replacement prescribed and achieved dose is one of the most important of them. If we're looking for a patient, 70 kilogram patient, hematocrit 30, and the amount of replacement, QP, is 150 milliliter per minute, the blood flow, and replacement fluid post-filter is 100,000. Pre-filter replacement is 3. Mix pre and post, 100 post and 300 pre. In this case, the replacement fluid will be 1,000 plus 100, 130. QD will 1,000 as I have mentioned, and ultrafiltration I need to be 200 milliliter per hour. So what about the dose? CVHF will be the replacement, 130, plus the ultrafiltration, no dialysate. FHD will be the dialysate plus ultrafiltration. And FGF will be the 3, dialysate, ultrafiltration, in addition to the replacement, divided by the patient weight to give it per kilogram, milliliter per kilogram. This will be translated into 21.4 milliliter per kg per hour, CVH. If we use dialysis, only 17.1. HDF will be 35.7. And you can see that the higher dose with CVHDF and the least dose when you're using only 17.1 HD. So as I have mentioned, it is waste to use CVVHD in this expensive modality. KTV over V is not applied here, but some studies found that we tried to use it in CRRT. Found that one-to-one relationship exists between the effluent and urea clearance when post-dilution CVH is performed properly. So clearance means post-dilution. Normalized effluent rate, why this? We have something is called prescribed dose and delivered dose. Prescribed dose is the dose that I am to prescribe. But is it really that reaches the patient? No. This is due to many factors. that the delivered dose is not the same as prescribed dose. It is usually lower. Why? Treatment downtime, as I have mentioned, volume overload, pre-dilution replacement carries less clearance, so less dose, multiple filter clottings, multiple circuit change, vascular access problem, and prescription errors, which is usually can be met sometimes. So these are the factors that resulted in the lower treatment dose. So please remember that the dose that reaches the patient is usually lower than the dose you prescribe. By how much? 1-to-1 relationship, and this decrease pre-dilution in CVVH, higher replacement fluid rates required to provide effluent dose frequently desired in clinical practice. Decrease in soluble clearance for pre-dilution is nearly 30 to 40%. If I am using CVVH only, the decrease in the dose is expected to be 30 to 40 difference prescribed than the delivered. اللي انا بوصفه اقل اكتر تقريبا من اللي بيوصل البيشنت بحوالي 30 ل 40 لو انا بستخدم بري دايلوشن ميثود اونلي. لو انا بستخدم بري دايلوشن، عشان كده post dilution should be used to minimize this pre-dilution penalty, which is called pre-dilution penalty. This is the pre-dilution penalty that progress with time. كل ما الوقت يزيد كل ما البنالتي ده الدوز تقل عشان البري دايلوشن only is used. So I am to use post dilution to get an infectious treatment. Higher blood flow rate 200 if I need to reach proper pre dilution. لو هستعمل pre dilution I should use 200 milliliter at least to compensate for this. In HD mode, use at least membrane which 1 meter, which is usual the case. If HDF, I am to use post-dilution method mainly and combine all of these things. Use post-dilution, not only pre-dilution, at least element, combine both, not depend on pre-dilution only. Use higher blood flow if I am using pre-dilution. لو انت هتستعمل pre-dilution زود البلاد فلو بتاعك عشان تكمبنسيت. والأحسن طبعا احنا to combine both treatments together. او ان احنا to depend only on post dilution لو مفيش مشكله في الانتي coagulation and use a higher surface area membrane. Higher prescribed dose 30 to 40 QB of at least 200 milliliter per minute. Coming to last part of my talk is the dose and outcome, and I will go rapidly through this. As we all know about all of these are all studies comparing dose and outcome. Higher dose having a better outcome or not. The start of one was Ronco. And the two major trials were ARF-ATN trial, ARF network, 2008, and renal study 2009, and both were published in New England Journal of Medicine. If you look, no effect, no effect, no effect, no effect, no effect, no effect, using comparing high and low doses. And the details of the studies are coming in the following slides. This is the one of Ronco. Compared 35 to 45 milliliter. Delivered dose, not the prescribed dose, which is lower. ATN trial compared 35 and to 20, and even compared to SLED 6 weeks or 6 times per week or SLED 3 times per week, comparing both together. All were in pre-dilution. To make it things more difficult, did not differ between the intensive and disintensive group. And renal study compared all to 35 to 40 out 25, and they found no significant difference or cause mortality 90 days between the two groups. Even ivory study 70 milliliter, no effect was found, and 80 milliliter, no. This came Cochrane the study and Cochrane trials, meta-systemic reviews, Cochrane reviews. The overall quality of evidence is relatively weak, and data from two relatively large multicenter trials, the ATN and renal trial, based on the available evidence, more intensive CRRT was not found to have a favorable effect on mortality or renal recovery. The only effect, nevertheless, indicates that the intensive CRRT associated lower mortality risk in post-surgical ICU. وده جه من الستادي بتاعت رانكو كان مولي على البوست-surgical اللي هي 2000 in Lancet paper. More intensive CRRT carries the risk of mainly of hypophosphatemia. These are the studies, summary of these studies. كان معظم الدوزز الاوتكم كان في 2025. Please look to this. These are survival in relation to effluent dose. This is published in Critical Care 2012. This curve, if you look to this curve, you can find that the curve nearly becomes flat or comes to its maximum in the dose between 20 to 30. This is the period of maximum benefit getting regarding mortality in dose mortality relation. No more effect coming into higher doses. And this is the same was 20 to 25 patients. Most of benefits came in this region. This led KDIGO 2012, they are in their last AKI recommendation, recommended that using CRRT, start intermittent hemodynamically unstable patient, suggest using CRRT rather than intermittent for AKI patient, acute brain injury or other causes of intracranial pressure or generalized brain edema. The dose of CRRT should be prescribed before setting each session, not to adjust your prescription during the session. We recommend delivering an effluent dose of 20 to 25 milliliter per kg. This is the delivered dose. In order to get this, you are to prescribe a higher prescription by about 30 to 35 or even 30 to 40 milliliter per kg regarding the amount of ultrafiltrate, the amount of replacement, and the amount of dialysate. So my conclusion, Mr. Chairman, regarding the principle of CRRT, it is a mainly slow, gradual process control of volume, intravascular volume, and solids. The main indication of CRRT is hemodynamic instability and comes to the first indication when the patient is hemodynamic unstable, in addition to some other indications, including acute brain injury and acute brain edema or a liver cell failure. Regarding modalities, please determine your modalities before start of treatment. HF, controlling filtration, or only dialysis, hemo-HD, or better to combine both regarding HDF. The use of membrane is usually of high flux, and it's much more better to use the newer membrane if you can. Replacement fluid usually bicarbonate, and adjust your need according to your serum potassium. Anticoagulation is usually with heparin, and take care of citrate if you are to be used in case of heparin-induced thrombocytopenia or any other disadvantages or side effects for heparin, to infuse calcium at the start and to infuse calcium at the last of after the filter, and to take care of total calcium to ionized calcium ratio in case of citrate accumulation or overdose, and dosing in order to deliver the recommended dose by KDIGO 20 to 25 milliliter per kg per hour. Please prescribe a higher dose of about 35 to 40 milliliter per kg per hour. And thank you very much.
Thank you very much, Professor Yasser. Professor Hisham, you want to start?
Hello.
Yes.
Hello, Professor Faisal.
أهلا.
أهلا بحضرتك.
Excellent talk. I really enjoyed Yasser, and it is deep in nephrology, and actually we need it badly now, and it is expanding and save a lot of patients. CRRT become one of the modalities which even ICU physicians start to share it with us and the nurses as well. But still, no one can understand what's going on except the nephrologist. Thank you very much indeed for this excellent talk. And now we can open it for discussion. I will leave the floor to Hisham to continue, and then we open for the discussion.
Thank you again, Professor Dr. Yasser, as usual, very comprehensive. And it is a very huge educational material. I think all the juniors should read that carefully and listen to your voice deeply and to all your slides. And if you allow me just to highlight some of the points before going to discussion. I memorized myself 25 years ago in the late 90s when we started CRRT in the Ain Shams University Hospital. At that time, we don't have replacement fluid. And we are, at that time, we were doing the replacement fluid by ourselves.
Yes.
I memorized that it's saline, bicarb, calcium, and we prepared the bags in cereals in the bottles. So my first publication was at early 2000. It was comparing 1 year about more than 200 cases of acute kidney injury with CRRT and the modality. appears that it is not saving life because of multiple organ failure. On the same time, with the progress, we don't have a solution for that. I will highlight some just to complete your very interesting talk for the juniors, just to have some terminology in dialysis in the two techniques. I would like to highlight the RAD, which is the renal assisted device, renal tubule assisted device. It was finished by 2006, although the mortality was less, but the functionality of renal tubule was scaring that we, at that time, the researchers stopped the publications because there is no availability of renal tubular cells. One of the, another terminology is the SPAD. We tried that probably 10 or 15 years ago. It was called single pass albumin dialysis. And SPAD is defining by using dialysate with 4% albumin, in particular in patients who have combined liver and renal toxicity and failure. The third terminology, you excellently described the prolonged intermittent renal replacement therapy. It is the mother of a prolonged dialysis or prolonged renal replacement therapy against the continuous, and it takes the advantage in COVID that you can use the CRRT machine for 12 hours just for 2 patients. And this terminology had been a great success in UK and other hospitals who has a little CRRT machine. My final comment in the terminology, just to highlight that for the junior, is what's called filtration fraction percent. If you are using hemodiafiltration, online hemodiafiltration, it is simply calculated by the ultrafiltration against the blood flow, and it should be in the range of 25% in the post-dilution mode. And if you are using CRRT, the filtration fraction should be as well between 20 to 25%. However, the measurement here is towards the plasma, not the blood flow. So we understand that it's more or less slowly. You definitely describe the cytokine removal. And I think the triple attack of cytokine removal depends on, number one, the membrane permeability that allows cytokine removal. Number two, the convection volume that augment the cytokine removal by the transmembrane pressure. Number three is the time to compensate the loss or the clearance by the production. So subsequently, for sepsis with AKI, we have to do the triple attack in order to have some of the good results. Finally, and we'll leave the discussion, the high cutoff and the high performance membrane. I think the high cutoff dies before it's born because it's a huge albumin loss. We cannot use hemodiafiltration with high cutoff membrane, so we have to use just hemodialysis like continuous venous hemodialysis with high cutoff, but we expect that the albumin loss could exceed 20 grams. So substitution of albumin, I think, is mandatory. So the medium cutoff and high cutoff is not.
The medium cutoff. What about the medium cutoff?
Yes, a medium cutoff is not for convection, high convection volume like hemodiafiltration, because as well the albumin loss will exceed 7 to 8 grams. However, in some center with COVID-19, they attack the COVID cytokine store with medium cutoff and CRRT in convection as a final step. But in general, if we are using medium cutoff, we have to use it in the hemodialysis mode, not in the hemodiafiltration mode, whatever it is online or what's online. The Japanese do with the high performance membrane, which is defined by class 5 dialyzer membrane, and use that only in pre-dilution mode. So this is one of the indications when to use the pre-dilution mode if the membrane flux is high and albumin loss. So I finalize my comment. I really appreciate the effort, the talk, all the solid information you perfectly described, and it will live for years as an educational material for the junior, and this is our task. I would ask you one question, simple question for juniors. What do you tell for those who don't have a CRRT machine and still have a slit technique in ICU? They should implement CRRT, or they can continue with slit by high permeable dialysis membrane, as the difference between both of them and the difficulty in the techniques is toward CRRT rather than the slit.
I think they should implement CRRT. We spend much money in many other sites and ignoring this modality totally. I think we are afraid of using this modality. We are going away, and as a SLED is present, we are usually go to SLED because it is easier. The staff is oriented with the SLED, and all can use the usual hemodialysis machine. And this kept us away from CRRT. But the problem is not that the cost. The problem is not that the cost. Money was too much more.
Staying in ICU is costing.
CRRT. We are to implement CRRT. No more infrastructures to be done in ICU. No more dialysis infrastructures. No more mobility of the patient to dialysis unit to do a SLED, for example. And this is of shame to have this modality and to go to SLED or other modality in the view of presence of CRRT machines and presence of solutions everywhere. Why not implement? This is the main modality in ICU. It's very easy to implement.
I fully agree that to implement CRRT, but patient selection should be toward who can do SLIT, for example, hemodynamic stability, hyperkalemia, and you can manage that selection. So if you have both modality, you can make some to choose between patients who can benefit alone from CRRT toward the hemodynamic instability. For sure, you can go deeply in CRRT.
Let me give it back to you, Professor Hisham. If you have CRRT and have a SLIT in your unit and equally available, why not to do CRRT and to do SLIT?
It is more complicated, more clotting, filter clotting, and it's very costly. But I have both in the hospital. But we can we can do for sometimes SLIT for more hemodynamic stable, and sometimes you need CRRT for more convection or patient with severe sepsis. I think that both modality is complementary, not this or this. Complementary.
PhD SLED is one of the modalities I have mentioned, but also all of these problems have easy solutions. To train nurses, and money is present for
not
many
too much
things,
present. Sometimes it's not present,
and easy to train staff and easy to use. Why not use and why not to implement and why not?
For example, if you have a patient with systolic pressure 110 and in ICU and he has volume overload state, hyperkalemia, oligoric, but is not on support, for example, and you can maintain hemodynamic stability, why not to go with higher dialysis membrane and SLIT, very easy technique, no complication like CRRT, filter clotting, and so on. But on the other case, if you have a multiple organ failure patients with systolic pressure 70 or 80 on support and complaining and has anuria, for example, and the very sepsis, cytokines is elevated, you can go CRRT. So both of them are complementary. It is not this or this, it's a complementary, and you can decide, but and it's sure that every unit should offer a CRRT station for critically ill patient whenever indicated. I will leave the microphone to Professor Fisher to handle the discussion and the questions, and to hear from other colleagues who are expert in the field of dialysis.
Thank you very much, Prof. Hisham. Usually you bring something which is, for us, is new. You bring the old things which always we forget it completely, but it is nice to hear it again.
Thank you very much.
I will agree more to have CRRT machines and to utilize it. If you have a trained staff, I am sure that nothing, no complications can come out of this machine. Especially we are using it in a very critically ill patient, even with hypotensive patients, with septic shock patients, and it worked very well. I will open now the door for discussion, and if anyone wants to discuss, to give a questions, and just to raise his hand or to unmute himself. I think someone is controlling this.
I think we have طارق طنطاوي, سعيد خميس, أيمن رفاعي, Professor Dr. Manal, Deep, all of our experts.
Yeah, so you can start.
Dr. Saeed Khamis.
Right.
Left.
Okay.
He's here. Yes, Prof. Saeed.
How are you, Professor Faisal?
Thanks, I'm okay.
Thank you. Thank you for Yasser for this elegant presentation.
Thank you, Professor Saeed.
Yeah, as usual. Regarding the number one, I think Professor Manal is asking about the cost. I think in some private clinics, maybe the cost more than 15,000 pounds per session, I think. But thanks God, in our hospital, in our university hospital in Manufia, we have two machines, two CRRT machines, and in the meantime, we get an approval from the hospital board to be almost free for any indicated patient, these CRRT modalities. So thanks for this board, actually. So any patient needs this CRRT, but unfortunately, maybe it is non-transferable, but I mean, it is almost free in our hospital, I mean the university hospital, right nowadays. Number two, one question, if you allow me, Professor Yasser, regarding one comment and one question. The comment is regarding what's called the indication for example, for CVHDF or any modality of this CRRT, I mean, mainly or namely this CVHDF. We can use it as a what's called renal supportive therapy rather than, or organ supportive therapy rather than a renal replacement therapy. In another meaning, we can use it as early as possible. Despite there is no support from the literature for this notion, but I think from our experience, and Professor Hisham and Professor Faisal can help us in this, I think it's better to start early when the patient is relatively hemodynamic stable, to improve the internal milieu to the organ to recover from or protect the organ from organ failures. Number two is regarding the antibiotic doses in CRRT modalities. It's challenging issue actually. So how can we manage this issue? Thank you. All
drugs, not antibiotics. All drugs, yes.
Yes, I totally agree with you, Professor Saeed, regarding your first point and your comment that we are early to initiate CRRT before we reach to the point that resistant volume overload. And if you remember on one of my slides, relative indications includes diuretic sensitive volume overload with oliguria. This is a very major indication, and really it will. I would be very happy if it become an established indication in the ICU to tackle this volume overload before it is established as irresistible problem. Regarding your second question,
the dose,
antibiotic dose, it needs a separate lecture. All antibiotics needs to be adjusted, and all drugs needs to be adjusted according to CRRT.
We are using a PDF file that is describing the dose in CRRT. So each drug now can modify by dialysis or hemodiafiltration, because some drugs are removed by hemodiafiltration, not by low flux. And on CRRT,
the modality, the duration, the use of methods of anticoagulation, the acid-base status, and all of these things are to be considered in prescribing drug dose. So that it needs a separate lecture and separate situation to adjust all drugs, not only the antibiotics, in case, especially and also inotropics.
For your comment, Professor Saeed, yes, it's organ support therapy. because simply what's happening in the kidney in sepsis could affect the lung, could affect the brain, could affect the heart. And so it is an organ support rather than a renal replacement therapy for the mechanism of sepsis. Yes, and it is described in literature that this technique can be used as an organ supportive rather than just a renal therapy. I think Professor Dr. Manal Edib is raising his hand, and I'm warm welcome to Professor Dr. Manal. You can unmute yourself.
دكتور هشام.
دكتور منال ازي حضرتك؟
Yes, I am unmuted. ازي
Yes.
حضرتك يا بيه؟ شكرا
Welcome
جزيلا على
on board.
المحاضرة دي يا دكتور ياسر. متشكرة جدا. شكرا للدكتور ياسر على المحاضرة الجميلة طبعا. We are enjoyed this lecture. وزي ما الدكتور هشام قال ان هي فعلا يعني ده مرجع بعد كده للجونيور يعني فترة طويلة. انا كان بس انا موافقه مع حضرتك يا دكتور هشام ان هو لو العيان يعني عندنا الفاسيلتي يعني مثلا ايه التكلفه بتاعتها 15,000 وممكن الممبرين حتى يحصل له كلوتنج تبقى التكلفه اكتر من كده. فلو عيان سليد سليد برضه يعني لو هو العيان مور هيمودايناميك يعني ريلاتيف هيمودايناميك ستيبل فليه ما نستعملش سليد يعني برضه فيه دي مش موجود بس CRRT في كل
Yes, it's your decision, Professor Manal. It is not a machine. It's your decision by your expert. So you can choose between both of them according to the patient needs. So both are complementary and both should be available as well.
I agree with you, Dr. Hisham.
To be afraid of CRRT. This is my point.
لا
no.
هو يا دكتور ياسر هي complicated فعلا يعني انت عارف عايز تمريض وعايز يعني مش سهله وبرضه بيحصل
in many studies in COVID-19 patient on CRRT, I understand the thrombogenicity of COVID-19, but the filter half-life was not exceeding 6 hours in those patients.
6 ساعات هو 6 ساعات فعلا وبيتجلط بعد كده
وبيتكلف
5000
جنيه. So you have the luxury machine of CRRT and you have the usual slide machine and you can use in between. Both still are complementary.
I think staff training now is can be done easily. It's not a major problem.
Yes.
We were trained for
it's an easy. It's an easy.
Trained for many other things. It's an easy to get trained the staff. And
بعد المحاضرة بتاعتك يا دكتور ياسر احنا فعلا يعني بقت اسهل بس يعني حتى مهندس الشركة بيجي يقول محاضرة مرة او مرتين انما يعني انت حضرتك يعني وضحتها بصورة جدا النهارده. وتريننج فعلا.
يعني هو لو الناس مش يعني الناس مش you are to want and do and push it and want really to push it.
بس نبداها بدري يعني فعلا نبدا يعني continuous replacement therapy يعني ديت نبتديها بدري مش لازم تبتدي متاخر بعد ما العيان
although the results of starting earlier than late in acute kidney injury does not give the chance of more better outcome, but it's again it's your physician opinion.
Excuse me, Professor Hisham, no better outcome regarding mortality and ICU stay. But in the form of symptomatic improvement and better patient control, yes, there was an outcome.
But finally, the mortality is high. Let me ask you a question technically.
Yes.
Sometimes the CRRT machine push the blood to the filter from downstream, not from the upstream. Sometimes the machine blood flow, arterial blood flow is from the downstream, not from the upstream. It's not common in all the CRRT machine. And I think, what do you think about that pathway? Is it beneficial for filtration, higher filtration, membrane pressure?
I really have no idea.
I think it's. I think there is no studies comparing on that with the blood flow, but I think the blood flow from downstream increase the filtration because of blood flow resistance. But there is no literature comparing both of them. So, Professor Dr. Faisal.
If I allow me, I probably will take another questions or two from the audience. If there is anyone, he can raise his hand or.
Yes.
Is there in the chat?
Yes, we have some questions. We have many questions on the chat.
Yes, I am sure. I will give you one question. You answer me if you don't mind. What about disequilibrium syndrome? And if you compare it between CRRT and conventional therapy?
Theoretically, will be better controlled in CRRT due to lower urea removal. Theoretically.
But usually, if we put the patient CRRT for 72 hours, usually, his urea and creatine come dramatically down. So there is significant change in his uremia.
Much more slower around for adjustment of intra and extravascular compartment, brain extra and intravascular compartment.
I didn't see anyone with disequilibrium, by the way.
Yes, exactly. No disequilibrium that, usually because it's very, very slow, inefficient, especially in urea.
Okay. Any other questions? Let us move. Who can you see?
Yes,
someone?
Yes, there is a question from Abdelazim, Dr. Abdelazim. How to prescribe citrate as an anticoagulation drug? It is not available in his unit, and it isn't available in the most of the units, by the way.
I mentioned the citrate pre-dilution, before the filter, and I mentioned the dose, and to inject calcium as antidote in the post-filter way. So
another question from yes.
One of my slides was for citrates regarding regarding the dose
yes,
the control of ionized calcium, serum ionized calcium in post
infusion post. Professor Dr. Manal T بتسأل what about lactic acidosis in situation other than metformin? I think she means that the patient was shocked.
Will be for sepsis and shock, which is
yes, exactly. From Khalid Abu Zaid, I'm saying hello, Khalid Abu Zaid. I know Khalid very well. I hope that you are well and doing well in Saudi Arabia. Khalid Abu Zaid has a very long experience in dialysis, and one of the who carry the dialysis in Mahad Nasser, I think, was Magdi Sharawi, is saying that first, delaying renal replacement therapy initiation with close patient monitoring might lead to a reduced use of renal replacement therapy, saving health resources. Second, on the most of the promising concept may be the development of renal assisted device, which died 16 years ago after some success in the acute kidney injury. So yes, he has a view that to save some money, again, it's a complementary and your decision. Professor Dr. Manal is saying that what about auxiliary filter in septic shock?
We used auxiliaries sometimes in the COVID area.
Yes, auxiliaries is grafted.
Yeah. And with some successful results, but we lack all major studies due to small number of patients.
You know that auxiliaries
hemodynamics and something like this, but only on one or two patient cases.
You know that auxiliaries is coming from the old membrane AN69, yes, which has a lot of complication. It is one of the optimizing AN69, but you know that AN69 has a high anaphylaxis with the ACE inhibitor. Auxiliaries has a grafted heparin and a sulfonated group for adsorption. However, the clotting in auxiliaries in the literature is high in patients with COVID as well. So the grafted heparin does not work well.
And this resulted in a lower CRRT circuits.
Sure, you have to you have to replace.
Some better outcome was found with this, but cannot
a
large number of patients.
Dr. Khalid.
Dr. Khalid Abu Zaid is raising his hands.
السلام عليكم.
وعليكم السلام. ازيك يا خالد؟
دكتور هشام ازي حضرتك؟
فين ايامك؟
حضرتك يا بروفيسور ازي حضرتك؟
الحمد لله.
شكرا يا دكتور. Very nice presentation. Really, I have a comment اللي قاله الدكتور هشام من شويه ال AN69. I remember since the 80s or 90s, can always they are reporting in handbook of dialysis AN69 making cytokines activation, especially with ACE inhibitor, and making a severe back pain, and we are facing
kallikrein system, yes, activating kallikrein system, kymine kallikrein system with anaphylaxis.
Yes, but my question, Akiki in his studies, as regard the early or late CRRT, there is no difference at all. There is no big difference. Especially there is a lot of colleagues said we have to start early, but actually, according to the Akikis, there is no difference in between early or late.
Yes, we just mentioned that.
My point, yes, is that it is mortality and ICU stay, Dr. Khalid, but on the view of symptomatic improvement and better control of the patient can be better alternative.
My question now, actually we are facing a problem. Is it an order of nephrologist or intensivist? Professor Faisal knows this problem well, but I want to ask you in Egypt, what is about this problem?
Professor Dr. Faisal said a very excellent word. They do, but they don't understand. So there is a difference between doing and understanding. So I think that all hospitals in Egypt nowadays are carried in the ICU, and the anesthesia and the ICU doctors and the physician can do, but still they don't understand anything about what's happening inside.
And nephrologists must be present anywhere in this story.
Yes,
exactly.
I think, Khalid, you asked me about this question, and I will answer you now. Maybe we have a lot of nephrologists. What I did myself, I trained the nurse in ICU about the machine, and I give the order as a nephrologist, and they work for me as a nurse, not as a doctor. The doctor doesn't interfere. So this is the best way to get rid of this. Get the nurse to work for you, because the nurse can understand the machine, and the good training is good for them. But the one who ordered is the nephrologist. And this is the
when to start, when to initiate, and when to end.
Excellent.
As well.
Calculating the dose, calculating proper membrane. And
They are doing that, but they don't understand what's happening in.
Yes, that's a conclusion.
Yes, yeah.
Dr. Umaira Ahmed عمارة أو عميرة؟
عميرة
اتفضل. هو ميوتد دلوقتي.
ايوه شكرا يا فندم على المحاضرة. My question is about the condition, specific conditions, يعني highlights about condition like hyponatremia and hypernatremia treatment with CRRT. يعني when do equations we face this problems in ICU situation, patient with hypernatremia or hyponatremia, we need to manipulate the content of the replacement, the dialysate or the substitution. It is better to give the 3% or the D5 water directly to the patient, or to manipulate the content of the bag.
I think no patient will have a single indication for the modality, Dr. Amir. Usually, if you have a hypotensive patient with hyponatremia or a borderline patient that Professor Hisham encourages for SLED with hyponatremia, this encourages more to use CRRT than SLED, or having a hypernatremia, for example. We have no single indication, especially in the ICU.
This indication,
you meet a patient, multiple patient with multi-problematic patient with many other indications. If one of them with hyponatremia, CRRT comes to the top of modalities.
Yes, but we don't do CRRT for hyponatremia as an indication.
Yes,
but it is yes.
Yes, no, multiple.
Yeah, just to be yes. It
yes,
is not.
If I am to do septic patient and patient with
you can calculate and you see that the patient with hyponatremia is euvolemic or hypervolemic. Probably with hypervolemia, yes. Probably with hypervolemia, yes.
I am mentioned in a specific situation to consider CRRT. Patient with hyponatremia, and usually, of course, having the indication for hyponatremia. For dialysis.
معلش بس دكتور انا اسف، هو بس سؤالي لو هو if the patient have high sodium 170 or 160, if I do dialysis with 140, it will be rapid correction. The same if 120 sodium, it will, if I do dialysis with 140, it will be rapid correction.
Patient عايز dialysis، لو البيشنت محتاج dialysis, the CRRT will be much slower than intermittent hemodialysis, Dr. Saeed.
I fully agree on that. And if you have a borderline between 10 to 15 millimole difference between the blood and the dialysate, it will be safe to go. Remember that one of the major cause of hyponatremia is hypervolemia, and should be corrected very early by ultrafiltration.
Yes.
We can go to the second question, if you allow me, Professor Faisal, from Wali Mansour. Wali Mansour is asking if the platelet count is less than 20,000. Is it considered contraindication to do CRRT? I think you have to mention that if it is 20,000 and the patient has TMA, thrombotic microangiopathy, you have to do plasmapheresis. But yes,
septic patient with DIC usually have low platelet.
sometimes, but not to this level, 20,000. But it's not a contraindication.
Not a contraindication.
It's a risky for the vascular access insertion.
It represents a bleeding risk, and of course,
vascular access,
and of course, heparin-free techniques carries a more risk of thrombocytopenia. And if this hit, for example, this complex situation.
Yes, important question is coming, yes, from the Wali as well. Is there any cutoff for CRRT with hypotension patient?
No cutoff.
No cutoff. You have to continue that. You can increase the level, but I think you can modify the doses of inotropics like the levodopa, and because you have to control that.
According to the patient situation, to maintain our aim is to maintain a stable session.
So you have to control that by increasing the dose because it's dialyzable in order to maintain. It's a very important point this to consider.
And this is usually the situation that we adjust inotropic dose to get a smooth session. Whatever sessions SLED or CRRT, but I am against to initiate inotropics for dialysis. Do you agree with me? As an indication to start dialysis in some hypotensive patient, inotropics are to be initiated for their indication and adjust according to the need for dialysis, but is to be initiated the patient to dialyze and readjust later on. I think for me, I do not agree with this.
Only patient with hemodynamic instability and hyperkalemia. The response comes after half an hour with a blood pressure elevation and something like that. The same hyponatremia, we answered that from Ibrahim. What is the precaution of using lactate buffer solution in patient with septic AKI? So you mentioned that it's nowadays it's a bicarbonate. Yeah, it's an old theory that. I think the same also applies for hepatic patient with use of lactate. There is no place of lactate right now for myself.
No place of lactate now.
Last question: is there any experiences coming from Abdelazim CRRT for acute rejection in transplanted patient?
I cannot get it as a treatment of acute rejection, or I was asking about one of the modalities of machine can be used in the plasma exchange.
Yes, exactly. If you have an acute antibody mediated, yes.
We can use the machine to do plasma exchange.
Yes, but it's not for CRRT. Either you can go directly, if it's antibody mediated, you can do plasma exchange or dialysis.
Professor Faisal in transplant can.
I think it's used if the patient needs dialysis and he is in sepsis and low blood pressure. Probably you can go ahead and do CRRT, but it is not for the rejection itself.
Yes, exactly. It is not a special indication.
Yeah. As Professor Yasser said, it can use as plasmapheresis, or if there is immediate rejection or something which you need to do plasmapheresis, it can be used. The machine can be used.
It can be used to do plasma exchange.
Yes, exactly. So I think we answered all the questions, and I will leave the microphone for Professor Faisal just to close and conclude.
Thank you very much, Professor. Thank you very much. And I think tonight we have one of the excellent talk, which, as it's mentioned by colleagues, that it is a talk which can stay for long and it can be repeated and repeated. We can learn from it. Even we are as a senior, we gain a lot tonight. Thanks, Prof. Yasser, for this arrangement. Thanks for all the audience, so all the colleagues from everywhere for their attendance for the late night. And I hope that we can see you in the next meeting. And Professor Yasser can announce this. Thank you.
Thank you, Professor Faisal, Professor Hisham. It's my honor to have you in this session today, and I really enjoyed all your comments and to increase the worth of this talk. Thank you for your comments and for your manipulations to be in the better way.
Thank you very much, Professor Dr. Yasser. As usual, your excellency and expertise in the field is an adding value to all of us. Thank you again, and have a good night to all, and wishing you a very successful clinical experiences, and thank you very much.
Thank you very much, and excuse me to close, and thank you for all attendees, all professors who attended and shared in this session. Our coming session will be Professor Hani Hafiz, highlighting the important topics of last nephrology congresses in 2022 and 2021, incoming Wednesday 9 p.m. waiting for you all, and thank you again. تصبحوا على خير والسلام عليكم ورحمة الله.
شكرا جزيلا.
شكرا جزيلا.
Bye bye.